Good evening, all. Namaskar. First of all, on behalf of the CCI, I welcome and invite all of you to the CCI webinar on pleurodesis. Before starting the webinar, I would like to congratulate and thank Dr. Ashish Dubey, the President of CCI, Dr. Anil Maske, the CCI Secretary, Dr. N.H. Krishna, and Dr. Narayana Pradima, the Chairman Trustee of CCI. Our special thanks to Dr. Vijay Kumar Channanchetti, the vibrant leader and CCI webinar coordinator, and is the master brain behind planning this webinar and today's webinar too. So before going to the topic proper, let me introduce my panelists. We have a very good list of panelists today. And myself he will be moderating the session. I am Dr. Jayaprakash. I am the Professor and Head of Pulmonary Medicine Department at present Government Medical College, Alappuzha, Kerala. And with me, I have Dr. Manali Patel. She is the Consultant and Critical Care and Palliative Care, Mumbai. Dr. Prriya, she is Consultant Thoracic Surgeon, Apollo Hospital. And Kogilaben Dhirubhai Ambani Hospital and Asian Cancer Institute, Mumbai. And Dr. Rakesh Godara from Jaipur. Dr. Shyam Krishnan, he is consultant clinical and intervention pulmonologist, CMRI and CK Birla Hospital, Kolkata. Dr. Prajay Lunia, he is from Mumbai. He is senior consultant chest physician and sleep and intensive pulmonary critical care physician. He is from Holy Spirit Hospital, Bharatiya Arogya Nidhi Hospital, Mumbai. And these are the panelists. I welcome my panelists also into the webinar. Now, let me introduce a brief introduction about the topic. Now, as you know, pleural disease are one of the most common clinical problems we encounter in our clinical practice. Pleural effusion and pneumothorax are the most common two problems we encounter. Adequate pleural aspiration and managing its etiology, or putting an ICD and looking into the etiology of pneumothorax will usually help us to resolve the issue. But when the pleural effusion or the pneumothorax recurs, I think we have to do something beyond the intervention of aspiration or chest tube and addressing the etiology. So there comes the role of pleurodesis. And one of the most common cause for doing pleurodesis, recurrent pleural effusion and recurrent pneumothorax. Now, pleurodesis actually is the artificial adherence of the two pleural layers together. We know the lung is covered by the visceral pleura and the thoracic wall is by the parietal pleura. When you adhere the pleural space with a foreign material and inert material, the pleurodesis will happen. And hence, further reaccumulation of fluid or air will be prevented. And as the CCI brochure says, bones strengthen relations and sometimes bonding the pleura saves life. I think it's a very good statement which I happened to notice in the CCI webinar brochure. From that point, I think we can start. As I said, recurrent pleural effusion is one of the most common cause for pleural effusion, most common cause for and etiology for pleurodesis. To speak on that, how to manage recurrent pleural effusion. Now we have with us. So regarding the how to manage the recurrent pleural effusion, we have Dr. Prajay Lunia from Mumbai. He will be giving the first presentation. After that, we have a short presentation on surgical means of pleurodesis by Dr. Prriya. After the two presentations, we will go for the panel discussion followed by question and answer. That is our plan today. And first of all, I invite Dr. Prajay from Lunia from Mumbai to give his presentation on how to manage recurrent pleural effusion. Over to Dr. Prajay.
Thank you, Dr. Jayaprakash sir, for the great moderation, and thank you CCI for giving me the opportunity for this wonderful topic of recurrent pleural effusion. Thank you everyone for joining in the evening for this webinar. As you can see in this photograph, a patient suffering from the big tube and the bad dressing with the pain. I would not like my patients or any other patient to suffer with this. So here we are to discuss certain things and come to a conclusion where we can help the patients to palliate in a better manner, to get treated in a better manner, and to avoid all this side effects of the big bore tubes and fistulas. Pleural effusion is what? Is nothing but a collection of abnormal fluid in the pleural space. Everybody knows it, the fluid normally comes from the capillaries from the parietal pleura and is reabsorbed by the capillaries of the visceral pleura and lymphatic system. Any condition which interferes with either secretion or drainage leads to pleural effusion. Transudative pleural effusion. It is accumulation of low protein and low cell count. It occurs either because of increased hydrostatic pressure or decrease of oncotic pressure. Exudative fluid, it occurs because of the increased capillary permeability leading to high protein and high cell count fluid. Other mechanisms are increased intrapleural pressure as in atelectasis and sometimes because of decreased lymphatic drainage as in mediastinal carcinomatosis. As you can see in this flowchart, either increased hydrostatic pressure or decreased oncotic pressure leads to shift of fluid from the vessel into the interstitial space and ultimately leads to effusion. Infection with the microorganism leads to inflammatory reaction, leads to dilatation of the vessel, increased capillary permeability, leakage of proteins, and decreased oncotic pressure, and ultimately leads to pleural fluid shift and leads to pleural effusion. Clinical features, you have to look for the symptoms like cough, dyspnea, pleuritic chest pain, loss of appetite and weight loss goes more in favor of tuberculosis malignancy, fever, hemoptysis, and hematomesis. Hematomesis tells you either probably underlying some GI malignancies or liver cirrhosis leading to esophageal varices. Signs, decreased breath sounds on auscultation, dullness on percussion, stony dull we say, asymmetric expansion, shift of mediastinum in form of tracheal shift, icterus suggestive liver disease, raised JVP, edema feet suggestive of cardiac involvement. To look for other signs that gives a clue to the cause of pleural effusion. Causes, transudative and exudative. I am not here to tell you because both are leading for recurrent pleural effusions. It is not necessarily unilateral. It can be bilateral also. Congestive heart failure, cirrhosis with ascites, chronic kidney disease, peritoneal dialysis, mixed edema, constrictive pericarditis, SVC obstruction, pulmonary thromboembolism, acute atelectasis. They are cause for transudative pleural recurrent effusion. They are mostly causes bilateral. Exudative recurrent pleural effusion causes tuberculosis, parapneumonic malignancies, connective tissue diseases, pancreatic diseases, sarcoidosis, mixed syndrome, chylothorax, post-myocardial injury syndrome. Any patient of pleural effusion, you have to do a certain investigations. Hemogram to look for CBC, hemoglobin, platelets. Biochemistry, look for proteins, creatinine. Chest X-ray, whether unilateral, bilateral. USG thorax to quantify. CT thorax to look for any underlying malignancies, mediastinal masses, cavities. Ultrasonography abdomen. Look for any ascites or any liver parenchymal diseases, kidney issues. Two-dimensional echocardiography, look for ejection fraction, IVC. Thoracocentesis, diagnostic plus therapeutic. Always ask for diagnostic plus therapeutic because you don't want diagnosis, you also want symptomatic relief. Send pleural fluid for investigation like routine micro, ADA, LDH, gene expert, AFB culture, bacterial culture, and cytology. Send maximum fluid for cytology, preferably in a heparized container. Always send serum protein and serum LDH simultaneously when you're sending pleural fluid. If above investigation not able to give you the diagnosis, go ahead with the thoracoscopy, either medical thoracoscopy that's called pleuroscopy or VATS. Lights criteria, pleural fluid upon serum protein ratio. If it's more than 0.5 suggestive of transudative, or if the pleural fluid LDH upon serum LDH is more than 0.6, or pleural fluid LDH more than 2/3 of the upper limit of normal serum LDH. So if any of the one, if it's positive, it's suggestive of exudative pleural effusion. But sometimes if a patient has a cardiac, renal, kidney involvement, and diuretics, it can give to a exudative picture, but it's actually a transudative. Do a gradient, serum protein minus pleural fluid gradient, which is more than 3.1 suggestive of transudative. Look for the appearance. That gives a good idea whether it's a transudative or exudative. A flow chart, which I've already discussed, like do investigations, exudative, transudative. If it's an exudative, look for the parameters. If not able to diagnose, do a CT scan, symptom improvement, and consider thoracoscopy if you're not able to get the diagnosis. Management of recurrent pleural effusion. Why is it important? Because the patients are suffering. We get recurrent filling, recurrent thoracocentesis, symptoms, palliative treatment. Most of them have underlying malignancies. So we have to treat the underlying etiology. If it's malignancy, treat malignancy. If cardiac, do a diuretics, high protein diet. If liver involvement, kidney dialysis. Repeated thoracocentesis. ICD or small bore pigtail catheter, followed by pleurodesis once the lung is expanded. Nowadays, in the era of interventional pulmonology, we are now more of using IPC, that is indwelling pleural catheter. Pleuroscopy, VATS, pleurodesis, spontaneous chemical and mechanical. Subsequent, next colleague of mine will discuss more in detail about pleurodesis. IPC, as you can see, there's a two X-ray, one which is showing massive effusion with mediastinal shift. With the help of IPC, the lung has started expanding. The shift of the mediastinum has come back to the central in position. These are the various parts of the IPC kit, which is available, marketed by Rocket. So one important thing I would like to tell you about the IPC, it's a chronic catheter which helps in the drainage of the fluid and sometimes helps in spontaneous pleurodesis. The only problem, it needs to be drained either daily or alternate day. Sometimes it can lead to the site infection or it can lead to infection of the pleural cavity. So it has to be very carefully used, your IPC catheter. Malignant pleural effusion, asymptomatic or symptomatic. If it's asymptomatic, treat the underlying cause. Symptomatic thorax, you do a therapeutic drainage. Lung, if it's expanded completely, do repeated thoracocentesis, or you can put an IPC or chest tube with pleurodesis, depending upon the lifespan, the other comorbidities and all that stuff. Medical thoracoscopy with pleurodesis. If it's a trap lung, the chest tubes are of no help. Put an IPC, help in drainage. Sometimes it can lead to spontaneous pleurodesis or with the help of the chemical agent. Medical thoracoscopy plus pleurodesis or decortication. Loculated pleural cavity, put in IPC or put in a tube. Put in a STK or altiplase, helps in fibrinolysis, drain the fluid, lung expanded, then do a pleurodesis. If not, then go ahead with your VATS. This slide I've specifically put because everybody feel recurrent pleural effusion is mostly with malignancy, but you can have with hepatic hydrothorax, you can have with heart failures. If it's with heart failure, optimize the patient with diuretics, additional heart medication. If still it is not improving, if the patient is developing symptoms again and again, that's called refractory symptomatic effusion. If the patient is a candidate for a thoracoscopy, fit for it, go for it. If not, then go for an IPC catheter. Similarly, for hepatic hydrothorax, give diuretics, give thoracocentesis, give high protein diets. If it's a refractory, go for transplant or TIPS. If it's not a fit candidate, go for your IPC catheter. Advantages, disadvantages. Best, I would say, is IPC in the now in this era. The second best would be either putting a tube, drain the fluid, go ahead with the pleurodesis. If there are adhesions or if it's a trap lung, go for a VATS, adhesional lysis, decortication, and then do a pleurodesis. The best part with the IPC catheter, it's minimally invasive. Only a disadvantage is it has to be kept for a longer time. There are risk of infection if you do not know how to use it. Never use IPC catheter if you do not have the social support, if the patient is not willing to take it home and do a daily drainage. A nutshell slide tells you about the various studies. Time to ample study, which tells you about the IPC related pleurodesis versus tube with talc slurry, and they found to be both equally effective. ASAP and amplitude study, which tells you the daily drainage of the IPC catheter has much more better palliation of the symptoms and faster pleurodesis compared to the alternate day drainage. Talc insufflation with the help of the IPC catheter, IPC plus study, ample 3 study tells you that it's equally effective with your tube slurry. There are various catheters I've been studying nowadays that which can be IPC impregnated with drugs with silver nitrate, which can be used for drainage as well as for pleurodesis. In nutshell summary, malignant pleural effusion, IPC is a very good option, followed by pleurodesis. Daily IPC drainage helps better palliation, faster spontaneous pleurodesis. Talc is the agent of choice for chemical pleurodesis. Equivalent outcomes with chest tube slurry versus thoracoscopic pouch. For non-malignant pleural effusion, treat the underlying pathology like congestive heart failure. If not getting better, go for IPC, drain the fluid, then pleurodesis. Hepatic hydrothorax, if the patient is not a candidate for transplant or TIPS, go ahead with your IPC. Chylothorax, dietary modification, medical therapy, thoracic duct ligation. If still not better, go for multidisciplinary approach. Thank you very much. I would like to specially thank Dr. N.H. Krishna sir, Dr. Vijay Chetty sir for giving me the opportunity, and I'm trying to do the best for this recurrent pleural effusion. I hope I did my best, and handing over my talk to my colleague, Dr. Prriya, who will tell you in detail about the pleurodesis. Thank you very much.
I'm Dr. Prriya Eshpuniyani. I'm a thoracic surgeon from Mumbai. At the outset, I would like to thank CCI and Dr. Jayaprakash for giving me this opportunity to speak in front of such an august audience. I would also like to thank Dr. Prajay for a wonderful comprehensive talk on pleural effusion, the causes, effects, and the treatments we can use for that. My topic for the day is a very small part of the entire talk, which is pleurodesis. As we all know, pleurodesis is basically instilling a sclerosing agent between the distal and the parietal pleural surfaces of the lung, which causes irritation, inflammation, and adhesion of the lung to the chest wall. The most common indication of performing pleurodesis is recurrent malignant pleural effusion, but we also do it quite commonly for recurrent pneumothorax and recurrent benign pleural effusion. There are mainly two types of pleurodesis. One is chemical and the second is mechanical or surgical. The chemical pleurodesis is inserting a sclerosing agent into the pleural cavity via chest tube. For patients who have already got an intercostal tube present, or we insert a fresh one, we use agents like talc, betadine iodine, povidone iodine. We use bleomycin, not very easily available, expensive and quite painful. And in our post-graduation days of 2003 to 5, we were quite used to using tetracycline. But nowadays, talc has become the agent of choice. It's cheap, easily available. It comes in pre-sterile packets. Though there are reports of ARDS and renal failure, but more or less, if it's used well, it is quite safe. There are surgical procedures also via either a medical or a video-assisted thoracoscopic procedure or an open thoracotomy, wherein pleurodesis is performed by either abrasion of the parietal pleura so that it creates a raw surface and the lung can go and adhere to the chest wall, or we perform it by a pleurectomy, in which the concept is the same, that there is a raw surface created over which the lung can go and adhere itself. Routine indications of chemical pleurodesis are malignant pleural effusion, refractory, symptomatic, non-malignant pleural effusion. For example, patients of heart failure, patients of nephrotic syndrome, chylothorax, wherein they are having a distressful life of a benign condition per se, recurrent primary and recurrent secondary pneumothorax. There are indications of mechanical pleurodesis, which are not we use it very commonly as surgeons, but for chest physicians, most of the times it's the first category of chemical pleurodesis, the patients which are more commonly referred to them. Mechanical pleurodesis, the indications are similar to chemical, with the added benefit of treating an underlying cause if present during the same procedure. For example, if patient has subpleural blebs or there are bulla, we are at the same time able to tackle them by doing a bulectomy or removing the blebs by ligation, and then doing a talc poudrage or a talc slurry at the end of the procedure to cause pleurodesis. It's quite more useful in benign conditions simply because it's a major procedure and requires the patient to be more fit and expecting a longer duration of survival. There are very few contraindications, but very clear ones. The first and the most important is the lung has to be completely expanded if you are planning to do pleurodesis of any kind, because unless and until the lung is expanded to the pleural surface, the chest wall, it is not going to adhere itself and it's going to fail. So once we know that we have a trapped lung or insufficient drainage, the lung is not expanded completely, don't perform it. It's a contraindicated thing. Previous thoracic irradiation, a chest tube which has lasted for more than 10 days because it already has a higher risk of having inherent subclinical pleural infection, more than 150 ml of output in 24 hours because it causes so much of fluid getting secreted that the lung is not able to stick to the chest wall. Lack of consent, very important. There are some also very few risk factors for death involved in pleurodesis. It's a very benign sounding but a very complex procedure. The first is a poor performance index, a poor body mass index, malignancy and male gender. I've had a patient who was a renal cell carcinoma, a young guy around 45 years, metastatic pleural effusion, who got pleurodesis done, came back after a week to us in ICU with severe breathlessness. In spite of best efforts for next 10 days, we just couldn't salvage him. So in spite of doing a very good procedure, you might just land up in death, and we have to be very well aware of that. Patients with a life expectancy of less than 3 months, you should not treat them with pleurodesis and manage them with a repeated thoracocentesis. That's a better palliation than a procedure which can cause more pain and more distress. When we instill a chemical sclerosing agent in a chemical pleurodesis, we can use it either by a tube, chest tube, a small or large bore chest tube, or an indwelling catheter. Most commonly talc slurry nowadays. It is more preferred to thoracoscopic or pleurectomy, pleuroscopy or thoracotomy because it is as effective, less invasive, and better tolerated by the patients. A thoracoscopy, pleuroscopy, or thoracotomy is preferred if there is an accompanying indication of thoracotomy, or else if we have done a diagnostic procedure, we have found malignancy which is widespread metastatic carcinoma. At the same sitting, we can go ahead and do a talc poudrage. When we have a chemical pleurodesis, the most common concept is a large size tube will give better results, but it is not so. A large bore chest tube gives more patient discomfort. pain scores are significantly higher, and smaller chest tubes have been associated with a similar rate of failure of pleurodesis at the end of 3 months when compared to a large bore chest tube. So there have been no advantages proven till date of a large tube over a smaller tube. So if a patient can get away with a smaller tube, less pain, more tolerance, we can give the patient that comfort. Most important, the concept of pleurodesis is causing inflammation. So when there's so much of inflammation, the procedure is intensely painful. The parietal pleural membrane is the highest percentage of pain receptors. That is why the post-thoracotomy pain syndromes are also so common. So induction of inflammation by the intrapleural instillation of sclerosant is highly painful. Routinely used by all the physicians and doctors are NSAIDs and opiates, but there have been some studies in animals which have proven that or suggested that NSAIDs decrease the inflammation and decrease the efficacy of pleurodesis. To describe the procedure of chemical pleurodesis in brief, the most important thing to remember is absolute sterile precautions. Absolute sterile precautions repeated multiple times before doing a chemical pleurodesis. We are instilling something inside the pleural cavity and can cause disaster if it's not maintained, sterility is not maintained. We drape the chest tube well, attach a good three-way stopper which is clean, instill lignocaine in the pleural cavity first, give that 5 minutes to the patient to the pleural parietal pleura to start acting, the lignocaine to start acting on it. We meanwhile mix the sclerosing agents like talc with around 40 ml of normal saline or betadine, povidone iodine with around 40 to 45 ml of normal saline. We keep everything ready. We dissolve the talc slowly and steadily, but we have to do it because once when it gets dissolved, if you leave it, it will get precipitated out. So once it's ready, we don't wait, we don't give it time to precipitate. You immediately connect it to the three-way stopper and instill it. Once that's instilled, you flush it immediately with around 10 to 15 ml of normal saline, close the three-way stopper and wait for 3 hours. Monitor the vitals very strictly. Post-procedure, we need good analgesia. If possible, NSAID should be avoided. Take help from a good pain and palliative specialist so that the patient can be given the best kind of analgesia. Brain is opened at the end of 3 hours if the patient is comfortable. A chest X-ray at the end of 24 hours, and if it's reasonably good and there is no increase of fluid or air, remove the chest tube and repeat an X-ray after 4 to 6 weeks. Mechanical pleurodesis, which is also called abrasion of the parietal pleura during the thoracoscopy or thoracotomy, or removal of the parietal pleura, or else placement of a tunneled pleural catheter which may drain the fluid and cause automatic pleurodesis without instillation of any agent. Not very commonly found, not very commonly performed. What we are more used to doing is an abrasion or a pleurectomy. A radical or a subtotal pleurectomy and decortication can control malignant effusions in patients, even those who have failed a chemical pleurodesis, because the concept is you strip the pleura off, so automatically the production of the fluid also is reduced. However, the patient has to be fit enough, a good surgical candidate, and should have a reasonable expected survival, because it's a major procedure and it has its own share of morbidity and mortality. It is quite commonly done in patients of mesothelioma where a surgical procedure is not very commonly possible. The complications of pleurodesis, like any other procedure, has its own share of complications. One of the most important is failure of the procedure because of increased tumor burden. There is inadequate response. Healthy mesothelial cells are in shortage, which are required to secrete inflammatory mediators. Patients can go into ARDS and severe systemic inflammation because of, especially in talc, because there is increased systemic absorption of talc. If you have created large raw surface, the talc is absorbed even in smaller size and can cause ARDS. Similarly, there is a activation sometimes of coagulation cascade causing a pulmonary embolism. The routine complications like fever, pleural infection, pain, general anesthesia side effects, atelectasis are commonly seen. Anaphylactic reaction is nowadays, with all the advancements, is rare, but it is known to be, and it should be we should be aware of it before doing the procedure. So basically, it's a very important procedure with patients with performance status who are symptomatic, who have got malignant effusions with reaccumulating effusions rapidly requiring monthly thoracocentesis. Instead of repeating thoracocentesis and drainage every month, we recommend to instill a small bore chest tube and perform clinical pleurodesis as soon as the drain fluid output has reduced to less than 150 ml per day. Interdisciplinary communication interprofessional communication between the specialists of medicine, surgery, oncology, pain and palliative specialists, very, very important. A good and good communication, a good transparent communication between the patient and the doctor, good control of post-operative pain, a good mobilization and the physiotherapy after the procedure, requiring a combination, a multidisciplinary team approach of physicians, surgeons, medical oncologists, pain and palliative physician, and a physiotherapist. The joining hands of all these people in a team will improve the outcomes of this procedure, which has a very benign sounding word of pleurodesis, but have a lot of complications in hand. So the focus is to have an integrated approach, integrated joining hands approach, joining hands, which is very extremely vital to the patients. More than happy to take any questions, and I've rushed because the time is short. It's only 10 minutes. Thank you so much. Questions are welcome.
Thank you, Dr. Prriya, for the excellent and lucid presentation regarding the various aspects of surgical pleurodesis. Especially thanks to Dr. Prajay also now looking into the various etiology of recurrent pleural effusion, both malignant and non-malignant, and explaining the role of pleurodesis with the chemical agents and IPC, etc. So they almost covered the topics, both covered the topics of pleural effusion and surgical aspects, medical aspects and surgical aspects. But we will take each points with the panelists and we will discuss. And along with that, we will take the questions to you also in between. Okay. Now, looking back to we will start, as we know, the pleurodesis started in 19th century by Spengler. After that, it's a common practice to do pleurodesis, which is one of the main part of our pulmonary medicine pleurodesis management. Now, let me ask Dr. Rakesh from Jaipur. Rakesh, are you there? You are not audible. Your mic is
muted. Yeah, I'm audible. Yeah, I'm here. Hi, good evening, everybody.
So can you just recollect the common indications and how you select patients for pleurodesis in your practice? Can you just give a outlook on that?
Yeah, so very important because the pleurodesis, as in the recent talk, so I will just summarize the things because we have listened to the two very good lucid presentations. So the common indication is first of all, the recurrent symptomatic malignant pleural effusion is one of the important indication for the pleurodesis. Second is the recurrent primary spontaneous pneumothorax or the contralateral first spontaneous pneumothorax or the secondary spontaneous pneumothorax where the comorbid conditions are there or the lung is compromised. Fourth one is very important where that it is the approach is not very clear in the guidelines and all, that is the non-malignant recurrent pleural effusion, and that is causing symptoms where the repeated thoracentesis and even after you're optimizing the background medical conditions, even if not sufficient and the patient is still symptomatic. Okay, the important thing about that, the symptoms we have seen in our patients with the non-malignant pleural effusion, especially the most common that we are talking in our clinical practice is the CHF. And so where that we can discuss about the pleural, because the other condition is the hepatic hydrothorax is difficult to manage where we generally do not prefer the pleurodesis and all. So where that all, then the patient, if he's having the recurrent the pleural effusion and we require thoracentesis, and then we can think of the pleurodesis in these kind of the patients. So these are the one of the common indications if we talk about for the pleurodesis. So that malignancy is one of the most common, that is the symptomatic malignant effusion, that is recurrent rapid refilling, because we generally say the 3R, and as we have discussed.
Thank you, Dr. Rakesh, for the excellent answers. And to summarize, you said the recurrent pleural effusion is the commonest one, and you do pleurodesis for recurrent pneumothorax with the various recurrent causes. Can you just tell me what are the causes where you do the pleurodesis in the first instant itself for a pneumothorax?
So the first, as I just said that about the secondary spontaneous pneumothorax, that one of the things where that we know about the patient is then because the patient with the COPD with the bulla, or the patient is having the that these are the very common because these patients have a very high risk for the like bronchiectatic patients and all. These patients have in even the first incidence, we should think of the pleurodesis because the chances of recurrence are very high. And in these patients, we know about that. First of all, the recurrence and along second one is that because of the poor, the pre-existing the lung functions, because any kind of the new pneumothorax will make the patients lead to the exacerbations and hospitalization and increase morbidity and mortality. So in these kind of the patients, we need to deal these patients in early and at first instance that when the patient have a secondary spontaneous with the poor compromised lung function, better to go for the pleurodesis because to decrease the recurrence and also make the patients less symptomatic.
Okay. So we will do the pleurodesis even the first occurrence when there is these factors, when there is a single lung or when there is a life-threatening first occurrence, even in special group of people like air crews, divers and all also.
Yeah, for the primary spontaneous, we can go for the patients who is a diver and all, or the pilot and special job is there. Where in the primary spontaneous pneumothorax, definitely we can go for that in special situation. Definitely. Okay. Otherwise, in primary spontaneous, we avoid.
Okay. Thank you, Dr. Rakesh. Dr. Shyam Krishnan, are you there? Dr. Shyam Krishnan? Dr. Shyam, are you there? Hello? Dr. Shyam? Okay. Dr. Manali, are you there?
Yes, I'm there.
Yeah.
Hello.
So actually, you are especially interested in cancer patients and palliative care, I believe. Yes, no?
Yes.
So let me ask, what is the role of palliative care in the management of recurrent pleural effusion? Both, malignant and sometimes you can add on to non-malignant causes also.
Right. So usually malignant pleural effusion, almost one in every 6 patient of cancer will develop malignant pleural effusion, and almost 2/3 of this patient will develop recurrent malignant effusion within 1 month of time. When they develop this recurrent malignant effusion, most of these patients are during their last phase of their life. So their survival is 4 to 6 months after developing recurrent malignant pleural effusion. So practically, if cancer patient is developing recurrent malignant pleural effusion, we are dealing with the last phase of their life. So as they approach further, their symptom burden will gradually go up and their quality of life gradually deteriorate down. To optimize their quality of life and providing them good symptom relief, definitely we can include palliative care in their multidisciplinary approach, and it can make patient as well as family's life more comfortable, and we can ease out their journey, which is obviously would be a difficult journey for them.
Oh, thank you for the excellent answers. Dr. Shyam, are you there? You are muted, Shyam. Dr. Shyam Krishnan?
Yes. Yeah, one second.
Yeah, okay. So can you just summarize what are the common agents which you are used for pleurodesis and your experience with that agents also?
So we have a lot of agents. I mean, there have been agents which have been tried left, right, and center. So you have agents like povidone iodine, doxycycline, bleomycin, autologous blood. But the best efficacy, what everybody recommends, most society guidelines recommend is using graded talc or medical talc. Initially, there were concerns about, having ARDS or something like that after using talc. But those were basically because of people using non-graded medical talc. So if the particle size of the talc is less than 10 microns, it crosses the pleural stomata and it causes ARDS. So the talc you get now, the French talc or the steady talc which we get now, the percentage of the particles less than 10 microns is very minimal. It shouldn't exceed more than 5 to 10% of the total volume of whatever 5 grams you have. So talc undoubtedly is probably the best agent. Dr. Gary Lee has been trying out agents like silver nitrate for pleurodesing, and especially in patients with mesothelioma. So these are the agents, and there have been head-to-head comparisons between different agents like doxycycline versus bleomycin. They found that bleomycin works slightly better compared to doxycycline. There have been head-to-head trials comparing povidone with bleomycin and doxy. So they're all small studies, but no properly framed randomized controlled trial. And if you see the efficacy of talc, basically it beats everything hands down. So the efficacy is over 85% for medical talc, whereas different studies for different agent quotes different numbers. So I feel in resource limited settings, you can always consider the use of doxycycline or iodine or bleomycin if it's a malignant effusion. If you have access to talc, stick to talc.
So you summarized like the best agent would be talc, no? You agree with me, no?
Yes.
Okay, so if talc is available, talc is the best agent, but you have to, there is a caution that the particle size should not be less than 10 micron and the amount should not be more than 5 grams and all. So the chance of complications are more. And in our resource poor country, like the one good alternative is povidone. Povidone, the thing you have to use 10% povidone. Normal, our povidone is not enough. You have to use the so-called povidone 10%, which the surgeons are commonly using. Other agents you mentioned like silver nitrate, doxycycline, for theoretical purposes, Mycobacterium parvum, then bleomycin, etc., can be used for, and the success rate varies between studies to studies. So that's a great answer. Now, Rakesh, let me ask one more question. When you add a fluorescing agent or a chemical agent to the pleural space, can you just explain how does this pleurodesis happens and what is the mechanism in very brief fashion? Can you just explain, Dr. Rakesh?
Yeah. So the mechanism is very simple. So it's more of to create an inflammatory reaction, basically. And the various studies have shown that even that moment you spray the podras or talc, and they have seen taken in the pleural biopsies, and they see the intense inflammatory reactions. So it's more of creating the inflammation that lead to the fibroblast activations, and that cause the adhesions. So this is one of the mechanism for all the medicated or the chemical agent mechanism. Second thing, the same thing can be created by the mechanical way where you do the scrub through your gauze, or a mechanical or partial pleurectomy. That same thing we can do by surgical mean when we are doing the VATS pleurectomy. So it's more of creating. That's why then we are avoiding anti-inflammatory agents, specifically that steroids, at least 24 to 48 hours before planning for a pleurodesis, because it interfere or hamper between the fibrosing reactions, basically.
Okay. So in short, you said it will create an aseptic inflammation, and subsequently there will be fibroblast proliferation, and the pleurodesis happens. That is a symbol. You put an agent, it produces an aseptic inflammation. Inflammatory cells are coming. Fibrous pathway is activated, and finally you get a pleurodesis. Okay, that's very good. Okay, Dr. Manali Patel. The second question I want to get an answer from you is, when you do the pleurodesis, especially in cancer patients, what is the peri-procedure symptoms and management which you can explain? No?
During the procedure or before procedure, they are quite breathless. Pain is relatively less if I compare with the breathlessness. But during the procedure and post-procedure patient, they go through a lot of pain. So mainly before procedure, dyspnea would be the first thing we need to address. And during the procedure, after procedure, analgesia would carry a very important role in this patient, because after procedure, pain is quite significant. We need to utilize opioids wisely and optimally for all these patients. Most of these patients, if they are in the ICU, we can continue them with continuous opioid. We can provide them analgesia with continuous opioid infusions, because most of the ICUs we have monitoring facilities. But if we are keeping them in the ward for cost or some resource limited settings, that point of time our analgesia prescription should be very opt, so that patient should not have NRS more than 3. So their opioid optimization is very, very important post procedure.
You also agree with me that non-steroidal anti-inflammatory drugs has to be avoided, preferably, no?
For animal model, they have shown that NSAIDs can NSAIDs can affect your pleurodesis because it has got anti-inflammatory properties. But if patients are in ICU, or even if they are not in ICU, optimum utilization of opioid with a lot of confidence can make them really comfortable their perioperative period.
Okay. Since you are having a lot of experience with the malignant effusion patients, what is your success rate like overall? And which agent you are using frequently for pleurodesis?
Sorry, Dr. Jayaprakash, this question is for whom?
For you only. Now you are seeing a lot of cancer patients now with pleural effusion.
For cancer patients, cancer patients, mainly we take care of their pain and other symptoms. For agent selection, we leave that decision solely on pulmonologist, intervention pulmonologist, or thoracic surgeon.
Okay, that's great. Yeah.
So I have a point to add, Dr. Jayaprakash.
Yes, please.
So there is the Najib Rahman group in UK. So they had published this Time 1 trial where they compared they compared opioids versus NSAIDs and a larger versus a small bore chest tube. So before there were no head-to-head RCTs, rightly said, So this was the first RCT of sorts, which basically debunk two theories which we usually harbor. One is use of NSAIDs. So here the non-steroidal anti-inflammatory they used in this trial was Brufen 800 milligrams given thrice daily versus morphine. And they found that Brufen given thrice daily, NSAIDs actually reduced pain better compared to morphine in the first 24 hours. And also that it was non-inferior to morphine in terms of affecting the success of pleurodesis. So now, especially in the UK, they've kind of removed it from the guidelines saying that you should not use NSAIDs. In fact, they say you can use NSAIDs for especially after pleurodesis. And the second thing the Time 1 trial showed was the use of larger versus smaller bore chest tubes. And the BTS recommendation in 2008 was basically recommended small bore chest tubes because based on just one study with 18 patients, which showed that it was better. But then this randomized RCT trial, which the Najib Rahman groups they did, showed that larger bore actually achieved 10 to 15% more success in pleurodesis compared to small bores. And larger size means they used 24 French. And small bore, they used a 12 French.
12 French.
So that were the two things which the Time study kind of challenged our beliefs.
So what is the conclusion like?
The conclusion is larger bore chest tubes are actually better, especially in patients for inpatient pleurodesis, and you can use NSAIDs.
Okay. Well, French and all, it's the failure rate is more actually.
Because it gets blocked when they.
But then one thing, Dr. Shyam, I want to add. Because one thing I want to add in this study, because they've shown that opioids are better for the pain control, and even in the arm of that NSAID where the background of your PCM was going on along with the Brufen, and in some patients they have to give the morphine also along with them.
Yes.
So I would like to just add, Jayaprakash sir, I would just like to add one thing here. With ICDs, it's very much working beautiful when you are having hemorrhagic pleural effusions preferably, because the small bore catheters tend to get blocked, like your pigtail catheters. And even if you're using a small bore pigtail catheters, preferable instead of using a 12 French, use little higher French catheters, you can use it, which are little more wider bore. And the only benefit with the pigtail is that the three-way can be attached, through which it becomes easy to do a pleurodesis. And with the ICD, you have to detach or use a 50cc syringe, puncture it, or you can use a synapse drain where you can do a pleurodesis without doing any puncturing and all that stuff.
Dr. Prajay, can you just recollect what is the role of synapse drain instead of our normal ICD?
So like almost 2 years before, I used to use more of like an ICD bag where we used to fill that water, the sterile saline, and you to get an underwater seal. And by the time when you used to go next day for the rounds, the mama maushi or the ward staff, I would say, they would drain that bag. They will consider
police catheter.
And when the time when you are going, there is no underwater seal, and then you are shouting unnecessarily. So it's like better than instead of that. No, I know it is little expensive, the synapse drain, but that is available in two varieties are available. One is a 400cc and one is 1000cc. If your daily drainage is not much, like not more than 300 ml per day, then I would prefer using a 400cc drain instead of a 1000cc. And with the synapse drain, it's a one-way system. You just have to instill 20cc of the saline to see the bubble, where you can actually see the air leak also if it is present or not. especially in cases of your pneumothorax. And with the help of a synaptic drain, there is no need of keeping an underwater seal. Automatically, it will drain the fluid, and there is a tap down where you can just remove the fluid and you do not need to clamp the tube also, because there is no risk of any fluid going or air going inside. And it's a very sterile instrument where there are no chances of any infection being introduced. And the pleurodesis also can be done with the side port very easily without introduction or decamping and detaching and doing the pleurodesis. I feel it is the best. And for attaching a negative suction, that is the best because it has a valve by which you can actually control the negative suction which you are using for the suctioning.
Right.
Okay. Oh, very good. Dr. Shyam, can you just say us, when you select the agents, is there any ideal pleurodesis agent or any criteria for theoretically what is an ideal pleurodesis agent according to your opinion?
So, pleurodesing agent is anything which can induce an inflammation and cause the two layers to stick together. That could be using sclerosant agents. It could be using, mechanical pleurodesing techniques like what the surgeons use. But I feel, so the ideal thing is whichever works is good, but the success rate depends on, it depends on multiple factors, not just the pleurodesing agent. So I feel talc is the best you got in the market now. The ideal one is the one which, when the lungs are together, it's the ease of installation, the least number of complications, least pain. So that is the ideal agent you would have. So talc pretty much works in that way. But then pain and all those things are basically, that's how inflammation works. Pain would be there. I mean, if there's no pain, you would... that's a red herring that, probably pleurodesis is not going to be as effective.
So to summarize, I think according to you, the best agent will be one which is safe, which is easily administered. It should be, easily available. It should be effective. And all these are satisfied with the TAC, but only problem is the with cost. So it's around 3,000, 4,000. The cost is the only factor. Otherwise, TAL could be the best agent. Okay. Yes. Okay. Now, in that background, Dr. Prriya, are you there? Dr. Prriya?
Yes, sir, I'm there, sir.
So we were discussing about a pleurodesis agent, which should be ideal. Like the cost has to be less. It should be effective. It should be free of complications, etc., etc. Can you just summarize what is the cost of pleurodesis, like especially in the surgical platform? Hello, you are not audible.
Cost would depend on which place. Hello, can you hear me, sir?
Yes.
Am I audible now?
Yeah, yes.
So cost would depend on which place are we operating, sir, like which kind of hospital, how resource constrained we are or not. So the cost in a outpatient, because we have been forced to do pleurodesis with povidone iodine in an outpatient department also, with keeping them only for 6 to 8 hours in the hospital. That would go as low as maybe 8 to 10,000, including all the consumables and everything. But if you go in a proper setting and if you want to do a task,
I think Dr. Prriya is disconnected. Okay. Dr. Rakesh?
Yeah.
Now we will wait Prriya to be connected. Now, can you just summarize when you do a pleurodesis, what are the common complications which are happening, or what are the complications which you want to anticipate when you do a pleurodesis?
So very important, because when we are planning for a pleurodesis, then one important complication we have to be very careful, and that we plan that it should not happen, because if it happens, then it is a mess. That is the one of the infection, because if a patient with the pleurodesis and if got an infection in secondary empyema, then it is very difficult for management, because then you have a loculated effusion with the secondary infections and all. And so you don't have access to the pleural space because it adheres somewhere and all. So that is one of the biggest complications. So that's why then in the slides also Dr. Prriya mentioned how the sterility is very, very important, that we need to keep in our mind. if you're planning, even that your place is, it could be your ward, it could be your ICU or your endoscopy suite, but make sure about that. Then the sterility and the that is very, very important. So the complication or the one infection is the one of the important. Second is the your pain, and that is one of the important things we need to consider. But as Dr. Shyam mentioned, that initially that, but I have seen in my experience that initially 3 to 4 hours the pain is more, and after that the patient don't have too much of pain, and that can be manageable very well with the routine, the opiates and all analgesics that we can use it as per the need. And then we need to keep in mind that what the creatinine and kidney functions that, and we can use NSAIDs if required. So then I have seen these two things very important. Third is the tube in the positions and dislodgement and all, because clamping the block that and that's why I've discussed that smaller tubes, because people suppose then if they have a pictal catheter and we try the pushing or the sclerosing agents, especially the talc and all, because the slurry they are thick, and we have seen that they get easily blocked, and after the block they're dislodged and very easily. So that's why then make sure about that your tube should be in a proper position, and after that you then keep a larger bore tube so that you have a less chance of the block and all. So the dislodgement is very important things, and the site infections and also with that routine are other the concern that we keep in mind when we are doing our chest tube insertion and thoracoscopy. That also, that is the common thing that we need to keep in mind. So these are the common complications. And fourth one is that bleeding. That one of the literature says, because the patient who is on dual antiplatelet and all, because it has been shown in the literatures, but then luckily till now then haven't encountered any kind of the significant, but then it has been seen that patient who is on DAPT, and if we go for a pleurodescent, then patient might have a high chances of the bleeding and all, because it caused the intense inflammatory reactions and all. Then some literature says that you better stop your the anticoagulations or antiplatelets, because if the patient, like suppose a patient of CKD and all, they have a high chances of bleeding. So these are the concern also we need to keep in our mind.
Dr. Manali Patel, actually, Dr. Rakesh was describing pain is one of the most common problem when you do pleurodesis. Now, in your cancer patients, do you increase the dose of morphine after doing pleurodesis? Or a second one is, do you add lignocaine when you do pleurodesis along with the pleurodesis agent?
Yes, both questions I'll answer one by one. Those who are opioid naive patients who have never received opioids before, their requirement of opioid would be definitely much, much lower than patients who are already on opioids. And as I have explained earlier that malignant pleural effusion, recurrent malignant pleural effusion, most of our patients would be last phase of their life. And most of them would be taking opioids for their pain relief because of the multiple cancer issues. So if they are on opioids, we need to increase their dose by almost 25 to 50%. So we have to always keep in mind that if they are opioid naive, their dose requirement would be much lower. If they are regularly on morphine or any other opioid, we need to increase their dose by 1.5 times. So one thing is that. And second, yes, adding lignocaine in pleural cavity, it reduces their post or perioperative analgesic drugs requirement, IV or oral drugs requirement significantly. So we always encourage intervention pulmonologist or surgeon to instill lignocaine in the pleural cavity.
Dr. Prajay, do you use lignocaine when you do pleurodesis usually regularly? You mix lignocaine with your agent?
So what I do is I first insert 10 cc of lignocaine before instilling the agent, and then I mix my lignocaine with the talc powder with the normal saline and make a slurry out of it, and then I instill it. So that by the time I instill my talc slurry, already little lignocaine is instilled, which goes into the pleural cavity, gives a little anesthetic effect, and then the slurry is instilled. And the most important thing, which I think is the counseling, is very, very important. That
Yes.
whenever you are doing any pleurodesis, you have to tell to the patient that you will suffer pain, just tolerate it for a few hours after that, because that is the maximum effect which is going to happen, because that is the time when your tube will be clamped. And once your tube is declamped and as the fluid starts draining, then the pain starts decreasing. So if they are able to tolerate that, and we have to tell them that if you get the pain, means it's like that dard ke aage jeet hai. It's like, because the more the pain if they get or something, that the inflammation is too good, and there are high chances that the pleurodesis will be successful.
Okay. Dr. Shyam, what is your take on this? Hello.
Sir,
Dr.
can I just say
Prriya,
something?
yes.
I'm sorry, I'm not putting my video on because my network suddenly became poor. So I
Please,
just wanted to add two things.
Yeah.
One is what Prajay said, that we instill lignocaine before the procedure to make the place a little anesthetized. But what I normally do is I involve my pain and palliative specialist before doing it, so that the patient does not suffer those few hours of pain also, because they're already a distressed kind of, they're living a very distressed life. So I think whatever possible, counseling is very, very, very important, and he's very right about it. But at the same time, I think if we involve someone who's better than us in pain before the procedure itself, we might give better relief to the patient. And secondly, sir, what Prajay had mentioned about Sinapi drains, I just want to add that I use it almost for all my patients now, because it's very good for home care also. Other than the ward, when patients take ICD home with their bottles, they end up getting infected or pulling out an ICD or disconnection. But when they carry a Sinapi drain home, the chances, I have seen a very drastic reduction in the incidence of empymas, and they're very easy to manage at home too. So apart from using them in the intraoperative or during the hospital, I also recommend them for palliative patients who have got a ICD in situ, or patients who can even of non-malignancy like tuberculosis or fusion. If the Sinapi drain is very easy to handle at home. So these are two all.
I have something to add with Dr. Priya's
please.
opinion.
Yeah, please continue.
Yeah, few of our patients who are not really fit for anything, and sometimes they will be going home with ICD, or they are going home with Pleurex or catheters, indwelling pleural catheters. So we encourage them, if they have a lot of pleural effusion, we encourage them to empty that, drain that pleural effusion every day. So there are success rate of almost 40 to 70% if they drain it regularly on daily basis. They develop a spontaneous pleurodesis if they drain it regularly.
Up to what percentage you get in your experience autopleurodesis?
Sir, actually data is varying between 40 to 70%, but most of the patients, they develop, like almost half of the patient, if they drain regularly every day with Sinapi drain. Actually this process has been actually become very simplified. It was really difficult with ICD bags, and with Sinapi drain and daily drainage, almost half of the patients who are not really fit for pleurodesis, they can develop spontaneous pleurodesis by daily drainage.
Okay, you use that negative section bottles for self drainage?
Yes, sir. And I also, sir, if along. No, sir. Sinapi drain itself has an auto pressure. It just does not use an underwater seal, and it has a one-way valve. So if the patient is counseled for some kind of physiotherapy, spirometry, or maybe balloon blowing exercises, if nothing else, that along with daily drainage of the Sinapi drain helps to achieve.
Hello. Again, she is disconnected. Dr. Shyam, everyone is asking about, after doing the pleurodesis, do you regularly clamp the chest tube, or if you clamp, for how long you clamp it?
So yeah, I do clamp. So I keep it, especially after I instill talc slurry or betadine iodine. So I usually keep it clamped for around 3 hours, and then I release it, and then we keep it. But if I've done a talc pudraj, then I connect it to negative suction so that the apposition is already there. The apposition is there, and inflammation takes place. So what I do is, so when I do thoracoscopy, I usually send the samples I take for frozen section or for an imprint cytology. So I get to know whether it's malignant or not within the time it takes, probably 15-20 minutes. And then if I get a sample which is positive for malignancy, then in the same setting, I do a talc pudraj. And in the settings where the pathologist is not sure of the diagnosis, he needs to look at the deeper sections of the histopath. So then I put in the ICD. Once I get the diagnosis of a malignant effusion, then I instill talc slurry, and then that's when I clamp the tube for 3 hours, and then I release it, and provided the lung is expanded.
Dr. Rakesh, what is your take on that?
So the same thing, because
clamping, huh?
Yeah, right. So earlier than I used to clamp that because the clamp is 2 to 3 hours is sufficient for that. But then so I keep some different approach for sometimes. Like recently I also mentioned that I hang up the keep a longer tube and then on the infusion bottle. So then I keep and then so there is no need to clamp it and you can keep it open because sometimes when I've seen that patients with the pneumothorax and all. So and after putting a slurry. So that is also one of the other option where then you do not need to clamp. So what you can do when you put a chest tube, then you can do your drainage bag, then keep in a long extended tube, and then it hang up to the your infusion bottle stand. So that also for serve as a water column, like column is there, a fluid column, and then it do not allow your slurry come out, and it remain there, and the patient will not because sometimes some patients might have a discomfort in the clamping. So this is one of the alternate we can use it.
Dr. Prajay, what is your take on that? After that, we will go to the questions. There are a few questions in the chat box.
So what I feel is normally recommendation is like 4 to 6 hours of clamping, but I feel 4 hours of clamping is decent enough. And in that 4 hours, if you after clamping, if your patient is having pain and if he is able to move in the bed, it is what I would recommend instead of just lying down in one position, because just moving with that, it helps in the movement of your that slurry inside the pleural cavity and helps in more inflammation and lead to more chance of successful pleurodesis.
Okay. And I think thank you all panelists for the excellent answer. We almost just covered the overall aspects of pleurodesis.
So
Now
can I ask one question, if you don't mind?
Yes, please.
So before we end, I just want to know the experience of all of you all. If for that pain and what we are saying, is there any role of a bugle or patch or any patches which we can use it if to avoid that pain a day prior or something?
My experience is almost zero on that aspect.
I'm not, but I just thought while this webinar was going on, so it just came in my mind. So I just thought,
Yes. I will just answer the question. Any patch for emergency or acute condition are not really advisable. Fentanyl patch is going to take 6 hours to start his action. And once that action starts, opioid delivery, if your patient is getting drowsy and if you remove that patch, that action is going to last for another 6 hours. So it's not a good option. And for bugle or patch, initially up to date data was suggesting that bugle or patch is going to take 7 days to work for to achieve steady state. Later on, I don't know how it has changed to 3 days, and now they say that in few hours it will start working. But most of the time, patient they do not get adequate analgesia by patch. So it's always better we can go by giving them IV, or if morphine is the best thing, like regular morphine, tablet morphine start working in 30 minutes. And control release tablet also we don't advise, because for acute pain we want quicker analgesia,
short acting.
and yes, short acting, and we don't want that action to last long. If like patient's requirement goes down, you don't want your patients to be drowsy. So morphine is very cheap, very economical option for analgesia, and other
Absolutely.
ways like you can go ahead.
I do agree with this.
Yes, injectable.
But Dr. Manali, to my experience, even though we talk a lot about this pain, this pleurodesis pain is not that great even with the TAR pleurodesis. Very rarely we require pain relief secondary to the pleural per se. And that's what my experience. Not that most of the patients are tolerating with the.
And that is also not long lasting. It's for just few hours basically.
Yeah, basically.
And that is also, it is much more seen with patients with pneumothorax as compared to your malignant pleural effusions, because your malignant pleural effusions, your pleura is already infiltrated.
Unfortunately, these patients are already going through a lot of pain. Pain is not merely physical pain. There are different aspects of psychological, spiritual, social, financial component to this pain. So whenever they are going through this more stressful situation, definitely their requirement goes up. So anxiolytics, optimum dose of opioid, assurance, and a multimodulary approach actually helps them in taking care of their pain.
Very correct. Actually, pain and symptom management in cancer patients is a totally different topic.
Yes. Physical part might be lesser, but other part will be too much for them to deal with. And most of the time, they know that they are going through their last phase of their life.
Exactly, very true. Okay, then we will take up the questions that also to be entertained now. No, Dr. Nikita from Haryana is asking how effective and how commonly you use povidone along with how effective and how commonly you use talc powderage. That is what her question.
The talc powderage versus slurry or talc powderage versus betadine iodine.
Povidone iodine pleurodesis, how effective and how commonly used, comparing with talc powderage. So she is just asking, can you compare the effect of pleurodesis with povidone iodine and talc powderage? Shyam, you can answer.
So talc definitely has shown a higher success rate, in terms of pleurodesis compared to povidone iodine. But then see, it all depends on how you use it. See, there are a lot of predictors. The most important thing when you decide to pleurodise a person is you have to see if the lung is expanded. Bottom line, the lung is not expanded well. What agent you use, it's not gonna stick well. It's not gonna stick at all. So the lung has to be expanded. Once that is there, the amount of pleural fluid which is draining has to be low. This recurrent, a lot of effusion which is being produced, you instill talc, you instill povidone iodine, the failure rate is going to be there. So you have to stick to those less than 150 ml drainage, lung well expanded. Then you can go and instill. So there, once you have this, these two conditions fulfilled, I feel talc works better than povidone iodine. But in resource limited settings, patient is not affording, povidone iodine works very well. So it varies between 75 to 84%. That's the number they are looking for numbers.
So it summarizes both povidone iodine and talc are good for pleurodesis. And if the resources are available, you can go for the first option is talc pleurodesis. And the povidone iodine is an equally good alternative. That's what you are confirming now. Okay. Now the continuation of the same question, Professor Shahjahan PS from Kerala, he is asking, is there any significant advantage for using talc when compared to povidone iodine? And what should be the agent of choice in a country like ours? Almost the continuation of the same question. Shyam, you can answer the question. Almost the same question.
So it's the same. I feel, see, if it is, if you're using it for malignant effusions, if you're using, and cost is not a factor, talc should be used. If not, you can use a good povidone iodine is a good substitute.
Okay. Dr. Rakesh, I think you can take this question.
So I think that's because
Ajay from Maharashtra, Nagpur is asking, I have come across few months back a patient whom I pushed talc immediately after xylocaine without waiting for 10 minutes. Patient was a case of recurrent pneumothorax. He had bradycardia and extreme pain. I stopped the talc, and do you have any experience on that? That is the question.
So here the pain is because of the vagal part, because we have seen the significant pain that lead to the vagal and bradycardia, and sometimes the patient, because of the severe pain, the splinting, because stop breathing and all. So though rare, but then it can happen because the patient might have a severe pain and then the vagal reaction, and patient might have a bradycardia. That is the one of the reasons. Secondary, so that is the one thing. But I have not uncovered, I think, one patient till now that I've seen that patient have a complication in terms of that hypoxemia and the bradycardia, because he was not able to breathe because of the pain. That is the one thing. So that's why then you need, if the patient is, that depend upon because if patient is sick enough, then better you go for all these things in a monitor setting, and better so you put in a monitor and all, so that where then you have all the measures to go for the management, because this troubleshoot can be there, but then better you have a management strategies, and you have all the medications with you to manage the things, including like oxygen, your atropine and all. So an ECG also, you can see the changes and all, then you can manage very well.
Prriya,
Sir, can I say something about it?
Prriya madam, actually you already put in the chat box that we needed to wait for 8 to 10 minutes.
Actually, sir, but Prajay has just mentioned 5 minutes ago that pneumothorax causes more pain than fluid effusion, which is what we have seen. So this patient which Dr. Jay has mentioned is the case of pneumothorax. And in pneumothorax, already the pain quotient is many times more. And if we are doing pleurodesis and if we're inserting something very fast, a closing agent, it causes intense peri pain, like how Dr. Shyam has said, for few hours. So if the lignocaine is being used, it should be used, and you have to be patient to wait for those 8 to 10 minutes before you instill the agent. That will, I think, take care of the perioperative pain during the procedure quite a bit.
Very good. Okay.
And after this question, I feel one point we should always take into consideration whenever you are doing all these procedures, there could be 1% chance of a serious complication like this.
Absolutely.
So you should always try to do
Absolutely.
these complications in a place where you have all backup monitors and everything available, and not just assume that no complication is going to happen except the pain.
Right.
Okay, well said, Prajay. So the next question, actually, I want opinion from all the panelists. Dr. Reshma KR from Kerala is asking, what is your experience with autologous blood patch for pleurodesis, especially when there is an air leak also? Blood patch for pleurodesis. I need opinion from all the panelists. Starting from, yeah.
So the autologous blood transfusion, because the studies, if we see from that, then very few patient studies are there. And in my experience, then only I have used in one patient, and where then, so very, very careful that, because in that patient, then unfortunately, then he had a secondary empyema, because there is one of the, so that's why then after that I stopped using, and I used in only one patient with the pneumothorax. So where and especially with the BPF, and when it can help us to block, if minor BPF, not the bigger, larger one. So after that, I have not used, to be for my personal experience, then only I've used in one patient. So though the literature is better, but then also the data are not very strong and encouraging, because we don't know in our patient then where somewhere the active infection is going on and you are infusing the blood into the sterile cavity. So that's also we need to keep in mind. So better than you just check for that, then you send the culture out, because all the patients then, so that's why then all these things we need to keep in mind. So look exciting that you just draw the blood and infuse there. So, but
so with your experience, you are not actually recommending blood, autologous blood, no? That's
I'm not too much in favor of that.
Okay.
And 30% of the patients might be culture negative, even they are harboring some infection.
Absolutely, that's right.
Pardon? We didn't hear it.
30% of the patients, they might be culture negative, but they'll be harboring some infection.
Still having the bacteria.
There is always potential infection threat.
Absolutely.
Dr. Prajay,
So I have no personal experience, and I would not recommend per se using autologous blood, because it's a very good medium for your bacteria to grow. I would not like to have more side effects compared to the benefits.
Dr. Shyam, what do you say?
So actually, so I had attended one of the meetings, where they had a session on treatment of persistent air leak, and the Western world says that the best evidence for closure of an air leak is with a blood patch, especially, but that's because they encounter a lot of cases which are post-surgical. For them, persistent air leak, majority of the cases are basically after a segmentectomy or after, post-transplant or certain lung surgeries, etc. So there it works well. In our country, most of the air leaks, especially the BPFs, are as a complication due to probably tuberculosis, and using the blood patch there. So I had two cases. One case I did use blood patch. It's because a patient recurrent pneumothorax developed BPF. He had a huge bulla. There it worked well. One patient, it did not work well at all. But then she actually had a tuberculous etiology for the BPF. And that we had to close it with a endobronchial blocker or a spigot. So the experience has been mixed. So I feel if it is post-surgical, if there's a persistent air leak, there you can always try a blood patch. Otherwise, if you suspect infective etiology, long-term, the chest tube is already there for a long term, then probably it's not a good idea.
What is surgeon's opinion, Prriya madam? You want to add?
No experience on this at all. I've never done it, so I wouldn't be able to comment on it.
She just mentioned better refer it to me.
No, you don't have any experience, no? Post-operative patients can. That is what Shyam was telling.
Yeah, I know, but I've never used autologous patch. I mean, I've never used it, so I wouldn't.
It's a good surgeon. She never had air leaks.
No, I'm not saying that. I'm just saying I've never used this technique to solve it. So I'm not a very honest surgeon.
Dr. Jyoti from Bangalore is asking how to reduce the complications of pleurodesis. I think we already discussed that.
Yeah.
And you have to use anything you want to add, Rakesh?
So
How
nothing.
to
This is more
only
of
mentioning the complications, no?
complication we have discussed about. It's more of the preparations basically. Yeah, it's more of the preparations. You have a checklist, and the patient selections are more important because so that's why then it depend upon patient selection. So then what site you choose for the pleurodesis, that's why then and your complications, even if they are, then you can manage very well. So the patient selection, what kind of the modality you are using it, and which site, whether it's a ward, ICUs, endoscopy, and the tube size, site infections, active infections, need to rule out all these things, pain optimally, the managed and all these things. So, and also that your check for the steroids basically, because our COPD patients and all, they are on steroids. Better to stop them if you're planning, because data are still there with the steroid, but not with the NSAIDs. So this is one of the things, and because there is strongly data for the steroid that they have seen the patient who are on steroid, they have high chance of the failure of the pleurodesis. So these are some of the things that, because in complication, one of the complication of the pleurodesis is the failure of pleurodesis. So that's why then it's very important. So all these things, if we keep in our mind, then we can achieve a successful pleurodesis for a patient, and we can get rid of the patient from the fluid recurrent effusions and also the chest tube.
Great. Dr. Prriya actually answered in the chat box itself regarding this question. So she mentioned you have to take absolute sterile precautions and preferably a setting with the good backup, good monitoring and good pain relief. These are the measures to be taken for reducing complications. That is the answer by Dr. Prriya. Then another question, which is how to select the correct composition of slurry. When you use talc pleurodesis, slurry pleurodesis, how to make a correct composition. Maybe the question is, if there is the powder, how you make into a slurry? That is the question. Anyone can take the question.
I think it's simple in the slides, and that it has been shown that the talc can be mixed with the 40 ml and 50 ml of your saline, and then you can infuse it through the chest drain, and either like you need to open it or from the three-way channel, or with the synapse, then directly you can, without disconnecting it, you can infuse it. So it's a slurry basically. That it's simple one. So you have to mix it very well, so that should not be kind of a clot and block. So it should be though it's a graded talc. So you need to mix it very well and then make it slurry, and then you can infuse it very. Do not push it very fast. You can infuse slowly.
So in short, you can take 3 to 5 grams of talc, mix with the 30 to 50 ml of sterile saline, maybe 5 to 10 ml of lignocaine also you can
that you can infuse earlier on.
Okay. Dr. Prajay, can you take this question? What is your opinion regarding minocycline 300 milligram for pleurodesis? Is it successful?
So it is a very good effective drug which can be used. Initial days when I was doing my residency, we used to use the doxycycline powder. We used to get 100 milligram capsule. We used to open it up and we used to use that powder to make that slurry, 5 capsules, 100 milligram. But subsequently, the company started stopping manufacturing, producing plain doxycycline. And that's why my strict explanation to everyone is, please avoid using doxycycline capsules nowadays because it has lactobacillus nowadays inside, and we don't have any evidence for it, whether it is successful or not. And they are not available in the powder form, they are available in the granules, which will never get dissolved. So either you can use doxycycline in the injection form, you can use tetracycline or minocycline. All three are equivalently effective, which can be used for pleurodesis.
Okay. I think Kumar Aman also asked the same question. What are the agents, tetracycline, doxycycline? We already answered that question. And Dr. Manali, one question actually I can take is, any anaphylaxis which happened with the pleurodesis till now, any single minimum cost-effective pleurodesis agent? You can answer the first question. Any possibility of anaphylaxis during pleurodesis?
Anaphylaxis can happen with any injectables. Any injectable. Definitely we are doing a procedure, so there is possibility that patient might develop anaphylaxis. So we need to have all backups to manage anaphylaxis.
Jodhima is actually eager to hear that how frequent it is. Is it to be worried about?
I haven't seen any anaphylaxis during this procedure.
Okay.
Sir, can I ask a
Another
question to the panelists? Is it
Pardon?
okay, sir? Can I ask a question to the panelists, other panelists?
Yes, sure, madam. Sure, please.
So, I had actually put it up in the chat box also. In two of my patients, one of mesothelioma and one of metastatic CA lung, I had done a window thoracostomy because they were not amenable for pleurodesis at all, and they still were good and well maintained. The metastatic CA lung was ALK positive, so he was on long-term crizotinib. So I want to know if anyone else has an experience of doing a pleurocutaneous window for patients who have got a mesothelioma or something which has got a fixed mediastinum, and but they are not amenable for a pleurodesis. So instead of an ICD a drain, is the window thoracostomy a good idea?
So
Actually,
sorry.
yes, please.
So as you were saying, like long years back, I had one patient where actually it was not created, but because that ICD was for a longer time, it actually created a kind of a thoracostoma. And then we had to apply a colostomy bag, which we use it for the drainage, and it worked very beautiful for as a palliative, I would say.
Yeah, so metastatic CA lung or mesothelioma post or whatever. So I think we say either we do a pleurodesis or we keep a ICD or a indirect catheter. So if patients are fit enough, I'm not talking about very end of life, but they are fit enough who are going to last for a year or so. Maybe in early, as soon as the mediastinum is fixed, we have patients who go like this because of the intercostal drain, and they are socially outcast because they have a drain. So is it an idea which we can actually start adapting more?
But then I
When two
would
patients
prefer
are good.
instead of doing that stoma, because there could be, because they have to change the stoma bag and there are chance of more introduction of the infection. Instead of that, I would still prefer using an IPC catheter. And now much more studies have been going on where they are using either silver nitrate impregnated catheters
Okay.
or drug impregnated catheters, which will act for drainage as well as it will help in the causing the
Spontaneous.
pleurodesis also.
And they're easily available, right? Because being a surgeon, I would not.
So silver impregnated catheters are available at some places, but the other are in the research.
Okay.
Dr. Prriya, what is your experience with the Helmish valve for persistent pneumothorax or sort of hydropneumothorax?
It's a Indian hemorrhage valve is a Eurobag. So hemorrhage valve for patients who have got a prolonged, say, collapsed lung with a cavity. If it's been prolonged and if there is a prolonged air leak, but if there's shift of not no mediastinal shift, it's a fixed mediastinum, then a simple Eurobag actually has sufficed in resource constrained settings. Hemorrhage valve is ideal, but innovation is the invention of our country. So for me, I have used a lot of places where there's a fixed mediastinum, a simple colostomy bag, a simple. My boss, Dr. Babatosh Vishwas, he used to use the mother dairy milk bag for patients who have got a fixed mediastinum with a prolonged collapse of lung.
Okay, correct. Okay. I think there is one more last question in the chat box. Dr. Jayaraman from Tamil Nadu is asking, is there any role for silocaine mixing with the talc or with bleomycin while you do slurry procedure? I think there is a role for slipinocaine, that already we discussed. And I think we discussed the overall what is pleurodesis.
So can I ask one question?
Yes, please proceed.
So, is there any kind of the role of because we know about the success rate of pleurodesis is near about 77 to 80%, because still that failure of near about 20% in the major trials. And we have seen the recent one TAPS trial where that they have slurry versus drug. They have seen the near of failure is near 20 to 20%. So can we increase this success rate up to the 80% by using the dual combination of any kind of the two agents? Is there any study, data, experience, any of the?
I think my opinion is
anybody have an experience?
Already there are studies saying that when you use dual agents, there is actually better effect when the first pleurodesis fail, or even there is a high chance of failure by anticipation. You can use dual agents. I think
is there any data or study or that kind? Because I haven't found any study like with the talc with betadine or betadine with minocycline, betadine with Dr. Shyam or anybody else? Dr. Prajay, Dr. Prriya?
Just the bronchoconstriction Dr. Mehta's team had presented their
Yes.
study on betadine
Yes,
plus
yes.
talc.
But
So,
is it used
so
at the
when I was training with them,
first procedure of pleurodesis?
at the
In
first
second?
instant,
First
first
instance.
So
instance.
directly
No,
they,
no,
so,
first
so
dual
what were
agent.
the, so what were their kind
So
of a
that
criteria that
directly
we
given.
have to use it, the dual agents for the patients? So is there any kind of the like, sir was asking that key any high
So,
chance of failure?
so I mean, I think so. In their study, they used recurrent effusions, especially non-malignant effusions. They were interested in that, especially hepatic hydrothorax, CKD or CHF patients.
So very failure rates are more.
But failure is more. So that's where they used it. And I don't know. So if talc, theoretically, talc basically achieves everything. So they say around 93 to 94% is the success rate. So then, so remaining 6% is what you're trying to get at.
No, because
By
no,
using the
the
double agent.
data
That's the
data do not
theory.
show about the 94% and all with the talc slurry and progress in the patient with malignancy. So
So
nowhere the
this is,
data
I
show
think
more than
so.
48. Yeah.
Yeah, I think so. It's just in one of the. So I think so. The Nick Maskell's group or the Dressler's group, one of these study they basically showed, but rightly said, it's not like it's never was an RCT. All these studies, it's very tough to design an RCT. You need, and even the best designed RCTs would be around 300 patients. It wouldn't be like over 1,000 patients and all that.
So because like
So,
as my experience, because I have used the same thing with the because 7 or 8 patients I have done with the hepatic hydrothorax, where then I've seen then the failure are very much. So initially then I have to use it with the like putting catheter again failed. So I put a catheter and betadine for 2 to 3 times. I have to put it later on. Then I used it combination, and because there then other solutions was not there, including the tips and transplant. So because then, and I found it most difficult with the hepatic hydrothorax in my personal
Yes.
experience. That's why then I have to use it, the dual agents, though I haven't found any study anywhere with it. So it show the claim. And
I
because
think
somewhere then
everyone will
it,
agree that the failure rate with hepatic hydrothorax pleural effusion due to liver failure is very high. It's very difficult to get a pleurodesis when this thing. Okay. Okay. So, Shyam, adding to your question, how can you predict that whether your pleurodesis is going to be successful or not before doing the pleurodesis? Any predictors?
So I feel lung expansion, sir. So lung expansion, if the lung is very well expanded,
Okay.
I feel that is definitely, a good reason that the pleurodesis is going to be successful. And obviously, the rate of formation of pleural fluid, the amount of pleural effusion or the pleural fluid formation should be less. The daily drainage should be less than 150 ml. A lot of times, sometimes you have. So there's this very interesting study by again the Najib Rahman group called the Simple Study. So where they use ultrasound to predict the or to evaluate the effectiveness of the pleurodesis. So they've used 9 points in the chest. So 4 points in the anterior part, 2 points for the lateral part, and the 3 points in the back. So in each point, where they put the ultrasound probe, they've assigned a score of 3, and they every day they check with an ultrasound. They look for lung sliding, and the moment so if they see no lung sliding in these specific points, you give them a score of 3. And if the score in all these points, if it adds to more than 20, that means your pleurodesis is successful. You can take the tube out. And so this has apparently shown that they reduce the hospital stay. They can pull out the chest tube one day earlier compared to the traditional BTS guidelines, where they required the pleural effusion or the drainage should be less than 250 ml, or the lung should be very well expanded on the X-ray. So use of ultrasound is one very good way to evaluate the success of your pleurodesis.
Okay. I think there is one question which Dr. Prajay can take. What is the role of silver nitrate for pleurodesis?
So silver nitrate, as we have already said, talc. Second is the best is the povidone iodine. Third is silver nitrate also works better. As I already told, there are certain IPC catheters which are available which is impregnated with silver nitrate. It acts as a beautiful inflammatory agent and helps in the good pleurodesis.
Okay, okay. Dr. Rakesh, you can take this question. Indications of things to be taken when you do pleurodesis for a AFB positive patient. on ATT? Anything extra to be taken care of?
So before that, then I just want to say and announce something that we have more than 1,200 logins. So just kind of an add on this thing.
Oh,
And
very good.
so your question was then AFB positive, then kind of any consideration because
Any consideration?
so it means then I'm assuming that a patient with the pulmonary tuberculosis with an extra pulmonary component in terms of either it's a pneumothorax or it's a pleural effusion coexisting. So why I'm requiring the pleurodesis, because I need to see. So I need to understand, or it is kind of your pulmonary tuberculosis with the pneumothorax with the leak and all. So that's the kind of things we need to consider because it's a more of the clinical scenario rather than hypothetical, because how we need to proceed. So one is the kind of you need to take care of yourself is a cough etiquette and all infection prevention. Second thing, then why we need the pleurodesis in an active tuberculosis patient with the pleura part, because in active disease, then generally we should avoid whenever there is active infections. So if the pleura is a part of the active disease of the tuberculosis, better you should avoid at least 4 to 6 weeks. And if it is a pneumothorax and leak, better to wait for that because it takes some time to heal that part. So these are some things that we need to keep in mind because it is a approach of the patients with the active tuberculosis with the involvement of your pleura. So how we need to go for because pleurodesis come in the last part of the management of the patient with the tubercular pleural effusion or a tubercular pyothorax or a pneumothorax. So then if we talk about or we are thinking of the pleurodesis in these patients.
Okay. Actually, that question was asked by Dr. Kumar Aman from Ranchi. I think Kumar Aman, we answered your question, I hope. I think we'll end up with one more question. Dr. Manali, are you there?
Yes, I'm there.
No, what is your opinion regarding prophylactic heparin during pleurodesis in palliative care patients, especially?
Prophylactic heparin.
Why?
Probably the person who is trying to ask is probably the
Embolism.
patient might be bedridden because of the underlying malignancy or
Yes,
something.
correct. Exactly.
Embolism.
Like that.
So many times malignancy patients, they are on anticoagulation because of some thrombotic events. So we need to titrate risk and benefit. Pleurodesis we expect only if we have survival benefit of more than 2 to 3 months. So if we don't expect survival of more than 2 to 3 months, we don't go ahead with the pleurodesis. Any point of time, if they are on blood thinners, procedure will be more complicated. Peri-procedure complications would be high. So if they are on anticoagulation, during the procedure, pre-procedure, we need to switch them on heparin or low molecular weight heparin. And then during the procedure, we can titrate. The way we are doing other procedures, anticoagulation to heparin and heparin to anticoagulation transition. Same we have to follow guidelines.
Okay. I think time is already over. It's 9:35. Any panelists want to add any important point? Then we will just take a minute and otherwise we'll close the webinar.
Just want to add one thing, as the Dr. Rakesh sir was telling about that TB case with a pleurodesis, as he rightly said that we need to know the background history and all that stuff. So
Correct.
probably the person who is trying to ask, what I feel is he is under the impression that if it's a secondary pneumothorax, example, a person having a tuberculosis with cavity and leading to a pneumothorax, so is it necessary to do a pleurodesis? So what I feel is if we are treating tuberculosis and we are able to resolve the pneumothorax with the ICD, I don't think so it is compulsory to do a pleurodesis because these are the very less likely to develop again a recurrent pneumothorax as with your COPD or underlying bullas. Because once if you treat tuberculosis, the cavity will always also get resolved.
Okay.
And
Dr. Prriya
secondly, it
also
is actually
opened in the chat
mentioned
box that
pneumothorax. Yeah, pneumothorax you shouldn't do pleurodesis at all in
yes.
pneumothorax. So
Yeah,
we have to just keep our drain in and
And
tuberculosis,
once
as
if
we
it is
said,
lung is expanded, you can actually remove the drain also.
remove the drain. Pneumothorax pleurodesis anyways is contraindicated in pneumothorax.
Absolutely, active infections are contraindication.
Yeah, and physiotherapy is a lot of forgotten branch. When we are doing pleurodesis for patients after 24 hours or whatever, we should encourage them, especially when we are expecting autopleurodesis, when we are putting synaptic drain and daily drainage. That time my network had got disconnected. We have to encourage physiotherapy, if nothing else, at least balloon blowing to those patients so that they have better chance of autopleurodesis.
Yes, expanded lung is always helpful for your successful pleurodesis.
Okay. Oh, so thank you all panelists. I think today I am very lucky and fortunate to get an excellent panel group. So as moderator, I even could not add much because all answers were perfect. I am very happy that we completed
You
almost
moderated
all
it
areas of
excellently, sir. Thank
pleurodesis.
you so much.
Yeah.
Thank
Sir,
you,
you moderated
Jayaprakash,
very
sir.
well,
Thank you,
sir.
everyone.
You moderated excellently, sir. Thank you so much.
Thank you, the technical team, for the excellent coordination.
Okay. So once
Thank you.
again, thank you,
Thank you.
Dr. Prajay, Dr.
Thank you.
Prriya, Dr. Rakesh, Dr. Shyam Krishnan, Dr. Manali, for your excellent answers and sparing your time for this CCI webinar. Once again, thank the CCI office committee bearers for giving us this opportunity to join together and give a session on pleurodesis. Thank you very much. Thank you, participants, for
thank
your
you.
excellent questions. We hope that
Thank
we
you.
could answer your questions very well. And thank you very much and good night.
Thank you.
Thank you
Good
so
night, sir.
much, sir. Thank you.